welcome to the 11th year of the International Tele-Grand Rounds. Welcome everybody to this Pan-American Society, University of Miami activity. This is going to be our first activity of 2021. I welcome everybody back. I hope everybody's safe. I hope everybody had a good holidays. I would like to say thank you for Dr. Dustin Price to prepare this case. It's a nice case here from Miami. And I would like to ask all you to reach out to Valeria Aguilar to start to book your case or presentation for the next few weeks. Okay. Thank you very much. Dr. Dustin Price, please welcome to this forum and can start the presentation. Thank you very much.
Yeah, thank you. Thank you for having me. So yeah, my name is Dustin Price. I'm a trauma fellow here at Ryder in Miami. And I'm just going to be talking about a case that we had several months ago. That was a penetrating neck trauma. It's a fairly interesting case. I have no disclosures. So this case is a 29-year-old male. He suffered a gunshot wound to the right neck. In the field, when EMS arrived, he had agonal breathing. They said he was in traumatic arrest. They started CPR, gave him 1 milligram of epinephrine. Sounds like they immediately got ROSC after that. They placed a supraglottic airway and then brought him immediately to the trauma center. Upon arrival to us, he was an unresponsive male. He had the supraglottic airway in place and we left it in for the time being, since it seemed to be an adequate airway at the time. He had palpable femoral pulses, and his first set of vitals showed he was hypotensive in the 70s. He was tachycardic to the 140s. On survey of this patient, he had a gunshot wound to zone 1 of the right neck. And as you can see by this cartoon here, the X designates the location of that gunshot wound. There was an occlusive field dressing that was placed. It was a pressure dressing. We removed this and there was brisk arterial bleeding coming from the wound. So one of the surgeons, actually Dr. Lieberman, who's on this conference, placed his finger through this tract, which did provide some temporary control. So while we had temporary control, we placed a 9 French introducer sheath into his left femoral vein. And we started a massive transfusion protocol. So this is just kind of the first discussion point, would be options for temporary control of hemorrhage from a bullet tract such as this, or like a junctional bullet tract. And then these are just the 3 that I've used in the past. I don't know if anyone has any other options or experience. Obviously we use finger occlusion in this case, which seemed to work. You know, there's been several instances with Foley catheters being used, and obviously you want to clamp the Foley catheter or tie a knot in it so they don't bleed from the catheter.
Dr. Alex, your comments, please.
So just a comment with regards to occlusion and bleeding control. I've used the Foley balloons before. Sometimes you have to use 2. You know, obviously a tending finger, that works too if it stopped the bleeding. If you still have bleeding after you put the first Foley balloon and you inflate the balloon as you said, and then I, you know, tugged on it a little bit, just make sure it doesn't come out, and then I put a Kelly clamp right across so it doesn't move with transport to the operating room. If I still have bleeding after that, then, you know, then I put a second one. You don't know if the bleeding is also intrathoracic. So if the balloon passes through the tract in the chest, you inflate the balloon and you just pull on it, you have, you know, you can get, you know, better control. Also, having the Foley balloon over there inflated also prevents air being sucked through the venous system and give you an air embolism. These are my comments. Thank you.
Thank you. These are just the anatomic.
Dr. Kassim. Your comments, please.
Good morning. So this is, I agree with what Dr. Alex is saying, everything. So I will amplify a little bit. The question is it a hemorrhagic arrest or is it a tension pneumothorax? You need to keep that in mind. Most likely, it's both. It could be both. So you have a supraglottic airway. Should that be changed when the patient is stable, at least, and not immediately? Don't change anything while you're winning. That's my motto in life. And I prefer the Foley catheter than to the finger. But then you may not have a choice. The finger that is in this wound is a very important finger. It's an attending surgeon's finger. And I'd rather have those fingers available to do surgery rather than occluding the wound. So keep that in mind as well. And once you have kind of stabilized it, I think I would go ahead and see if I should entertain putting in a right chest tube to see if this intrathoracic bleeding or not. A chest x-ray will be useful as well while you have the occlusion control of the bleeding. And I cannot emphasize more, stop the bleed, stop the bleed, stop the bleed. That's the priority number one in a case like this. And I would definitely entertain the possibility of having a chest tube on the right side as well. And a chest x-ray to look at the trajectory, what other things could possibly injured. And he's alive and hemodynamically marginal. And he's a young fellow, so he'll probably he's compensated. So I would definitely give him blood transfusion rather than crystalloid. And those are my thoughts. Eventually, this patient will end up in the operating room. How soon is questionable at this moment. Should I go to any other imaging modality is questionable at this moment, but I'm in the resuscitative phase still. So all those things are going through my mind at this moment. Thank you.
Thank you, Dr. Kasim. Iraq, Dr. Untract, your comments, please.
Yes, so I agree, obviously, with all the comments by Dr. Alex and Dr. Kasim. This brings back flashbacks to another trauma case, a similar case that we had in a young woman who was shot almost in the same location. This one's a little lower than hers, but on the right side. And I'm wondering, was the assailant left-handed? That the two patients now shot with an entry wound on the same side, no exit wound. And, the fact that it's a young guy and they got spontaneous, return of spontaneous circulation with a single injection of epinephrine, it could be hemorrhagic shock, especially if the right chest filled with blood, or I'd be concerned, like the other case, that it's another example of spinal shock where a gunshot wound obliquely at the base of the neck would be expected to, in this case, hit the vertebral column. So my concern would be that you have control of the bleeding and you want to sort of sort that out initially. And with the finger control, especially if the patient is now stable, the blood pressure is coming up to about 90 systolic, then I think you can do a little bit more evaluation. You can secure the airway with a definitive airway and evaluate the chest. So initially listening, and then with the ultrasound, and I would do a chest X-ray in this case to see if the patient is being well ventilated at this point, and then there's no blood in the chest, then it looks like the wound is entirely in the neck. And at that point, I might consider trying to get hemostasis with the Foley catheter balloon, specifically to then enable, if the patient is now stable, a better evaluation. I would do a CT scan of the neck to see if it's like the other case, if the spine has been stricken by the bullet, and then the spinal cord is no longer viable, in which case, you know, do you need to go to the operating room to pursue a pretty much a futile operation? And you can also check to see if are there any pulses at all, are the extremities flaccid, not pulses, but reflexes. If the reflexes are flaccid, completely flaccid, that might suggest a, you know, devastating injury to the cervical spinal cord. So that's what I would add to this. Try and determine, is the spinal cord completely, is the patient quadriplegic, and is the prognosis very poor on that basis? So that's how I proceed.
Thank you, Dr. Untract. Dr. Peralta from Qatar, are you here, sir? Dr. Peralta? Okay, Dr. Calais, good morning, sir. Thank you for joining.
Thank you. I can't see the initial the case.
Okay. Since everyone always appreciates your feedback, Dr. Price, can you give like a 1-minute synopsis for Dr. Calais' benefit, please?
Sure. It's a 29-year-old guy with a gunshot wound to zone 1 of the right neck with arterial bleeding. He arrested in the field, came back with epinephrine and CPR, and then he presented to us in presumed hemorrhagic shock with arterial bleeding coming from the gunshot wound in his right neck. And we have a surgeon's finger occluding the bullet tract, providing some temporary control.
Yes, in this situation, is if possible, can you use your finger and control the hemorrhage, and then put the access to start to see where is the vessels. You can put a Foley catheter through the hole in the neck and try to occlusion the hole and try to control the hemorrhage. And in some cases, in this situation, you can put your finger. If you have control for, I can put sometimes I see, I don't know it's possible, can put a balloon. If you have a table, can put a balloon and occlude the vessels. But in this moment, I think the most problem, I go to put the Foley catheter and then go to a surgery to start to control the hemorrhage. Okay.
Thank you, Dr. Calais. And Dr. Weir from Ryder. Do you have input, sir? Okay, Dr. Weir. Anyone else have any input additionally before we return to Dr. Price? Okay, back to you.
I can say something unless someone else.
I'm sorry, Dr. Liebman. Go ahead, please.
Yeah, so this was obviously my case, and I think everyone's suggestions were really good. I like the idea of the Foley, but to be honest, as soon as we took off the dressing from this patient's neck, it was like a fire hose of blood squirting out, and pure, just instinct and I guess training. Right away, I placed my finger, and I don't know how, but I managed to get control of it. And once I did, there was no way in my mind I was going to remove that finger and try to get a Foley in and not be successful. He probably, the way he was bleeding, I'd say 30 to 40 seconds, he would have completely bled out and arrested. And then once it was controlled, we obviously knew what the next steps needed to be, but not knowing the extent of the injury and pretty confident that he would have a lot of, hematoma in the neck, a definitive airway was obviously the next thing, because if we lost his airway, then, no matter what we were controlling with my finger, it wouldn't have helped. So I think those were the most important things was, in this case, 1, stop the bleed, 2, protect the airway. And then I guess Dustin will continue from here. But it was one of the most impressive neck bleed, hemorrhage cases I've ever seen. And I've been at Ryder for 12 years.
Thank you, Dr. Lieberman. Okay, let's go back to Dr. Price for continuation now, please.
Okay. So next step in management, we kind of discussed this, like, several people gave their opinions. As Dr. Lieberman said, we had very profuse bleeding. So our main goal was get a definitive airway and proceed to the operating room. So we brought this patient directly to the OR. He was intubated by the anesthesia team. They placed an arterial line. We prepped the patient and performed a right neck exploration. While we were, in our initial neck exploration, it was apparent that he had very brisk arterial bleeding coming from behind the right clavicle. So this is another kind of discussion point of how to proceed from here, the possible structures involved, and how to obtain vascular control.
Gary?
Anyone like to comment?
Yeah, just sorry about that. My mic wouldn't unmute. Let's go to Iraq. Dr. Untrack for comment, please.
Yes, okay, so I think it's pretty straightforward here. It's very low in the neck, zone 1, bleeding behind the clavicle. So, and you're already prepped for it. So I think you need to do on the right side a median sternotomy to get control of the carotid and the carotid and the subclavian arteries on the right side, proximal control. Start there, and that should give you reasonable access, and you may need to extend the incision to if you can't get access to the to all of the subclavian artery, but I would start with a median sternotomy.
Thank you, Dr. Untrack. Can we go to Sao Paulo, Dr. Calais?
Yes, in these situations, the patient can explore the artery in this position. In this position, we can have injuries of the subclavian artery, carotid artery, troncobrachiocephalic injury artery, and venous brachiocephalic venous in this position. So to approach in these situations, you can start with a incision in the neck. Usually in these situations, I can go to extend these incisions to a sternotomy to control the proximal portions of these vessels. That's the way I can go to start the operation.
Thank you very much, Dr. Calais. Let's go to Portland. Dr. Kasim, your comment, sir?
In a situation like this, with the finger in the dike, and you need to get to the access very quickly, I think I would like to do a clavicular incision and resect the clavicle very quickly. I think I can get to the area of the bleed rather quickly by removing a portion of the clavicle, and then make a determination what direction I'm going to go, whether I'm going to capillate or I'm going to extend it downwards into the mediastinum. In my opinion, I think clavicular incision gives me the quickest access at this moment in this case. Thank you.
Thank you, Dr. Kasim. Philadelphia, Dr. Alex, your comments, please.
So in the operating room with the airway controlled and MTP running, what I would do is actually do a pericardial view of with the FAST. If there is blood in the pericardium, then it's just a matter of time until he's gonna arrest and code. If that's negative, then I would do what my colleagues mentioned with clavicular incision and be ready to extend down in the sternotomy or go up on the neck for control of the carotid if that's what's bleeding. But I think I would put a probe on the pericardium and see if there is any blood, because then he'll arrest, and then you may have to do a thoracotomy on the left side to just bring him back and release the tamponade. Thank you.
Thank you, Dr. Alex. Dr. Lieberman, anything before we return to Dr. Price?
No, just keep in mind that, my foot was still in the wound. That was pretty much the only thing that was keeping him from bleeding to death. And I guess Dustin will tell you sort of what we did. And yeah, in the back of my mind, I was thinking right subclavian artery injury, common carotid injury, or even both.
All right. Thank you, Dr. Lieberman. Any other comments before we return to Dr. Price? Okay, back to you, Dr. Price.
Thank you. Yeah, so our thought process was kind of along the lines of everyone else. We thought this was going to be a major vascular injury to either subclavian, carotid, and we wanted to get quick control. We discussed, I think, both options in the operating room briefly. We ended up proceeding with this median sternotomy to get better control of the aortic root and great vessel exposure. We opened the pericardium. There was no blood within the pericardium, so there's no injury to the heart or the aortic arch. We did ligate the left innominate vein so that we could get better access to the brachiocephalic artery on the right, or the brachiocephalic artery. We did place a clamp over this artery, but it really didn't provide adequate vascular control. We then dissected further the common carotid artery and then moved our clamp to the common carotid, which also really didn't provide much control. It didn't appear that there was a subclavian artery injury. We were able to expose a good portion of the proximal subclavian, and we exposed the entire area around Dr. Lieberman's finger that was going into the bullet tract. The right internal jugular vein was more or less destroyed. It was completely transected and really was not amenable to repair. So this was ligated. There was a significant amount of bleeding coming from this vein. And then the bullet trajectory, once we exposed everything, appeared to be going posterior, medial, and inferior towards the cervical spine. And then when we removed our finger again, there was still brisk bleeding coming from deep within this bullet tract. So what does everybody think about this source of hemorrhage and getting control here?
Dr. Kasim, Portland, your comments, please.
So when you remove the clamp and there was brisk bleeding from where?
It was bleeding from deep within the bullet tract towards the cervical spine.
Right.
So we had a clamp on the brachiocephalic artery, which didn't seem to provide any significant hemorrhage control. And then when we had moved the clamp to the common carotid, it also did not provide control. There was no injury to either of those structures.
So I would be looking at the first portion of the subclavian, and there are 4 branches coming out of that, and one of them might be bleeding through a backflow.
Mm-hmm.
So I would dissect out the subclavian, the right subclavian from its origin, and then get the branches there and put a vessel loop and to see if I can identify which one of those 4 branches could be bleeding. And as long as he is not hemorrhaging profusely, like Dr. Lieberman encountered initially, I think I still have time to get control of this bleeding. That's what I would be doing.
Thank you, Dr. Kasim. Philadelphia.
I'm talking to you about the thyrocervical trunk, one of those.
And keep in mind, the bleeding had slowed a little bit once we had ligated the internal jugular. So I think that was contributing to a lot of his hemorrhage, but he was still bleeding.
Okay. Dr. Alex?
So a clamp on the right brachiocephalic should control and should stop bleeding from the subclavian, carotid, and all those branches, including the thyrocervical trunk. With the tract deep towards the spine, the concern is vertebral artery for me, and that probably can still bleed even if you have proximal control if there's collateral flow and just kind of coming from like top down. So with this in mind, I would try to mobilize everything in such a way so that I get on the spine at that level carefully and see if the bullet tract goes like straight into where the vertebral artery would be. And then I would decide, what I would use if I see, breast bleeding coming really from the transverse processes or whatever that those are injured. And then I would, maybe put a balloon there, or maybe put some Austin or something to just, control the bleeding. And then after that's done, then I would be thinking CT angiogram to see what else is going on with regards to perfusion of the brain and the neck. Thank you.
Thank you, Dr. Alex. Iraq, Dr. Untract, your comments, please.
Yeah, so, the description of the bleeding, I assumed it was pulsatile red arterial bleeding. When you say like a fire hose, it sounded that way. So, so that was my assumption, and maybe you can clarify that. The other thing is, can you clarify where the bullet wound, the entry wound in the bullet tract, course relative to that diagram that you have on the right side of the slide? Did it go between the carotid and the subclavian medial? So I want to know that.
It was just lateral to the common carotid and superior to the subclavian.
So going posterior medially behind. So what I would do, and what are we looking at there? Where's the
head is at the top?
Okay, I see. Yes. Okay. What I would do is I would explore then medially to the carotid artery, to the carotid sheath, and see if you can pick up the tract, and you should be able to see the trachea, the esophagus, and then the anterior part of the cervical spine, and get a better idea of where the bullet tract goes. And maybe you can actually feel it with your finger in the tract. We're able to feel the spine at the end of the tract, or not. I mean, that you might be able to just explore digitally, but that's what I would do next to get the better view to try and intercept the course of the bullet medially and posteriorly. So that the best approach for that is medial to the great vessels, to the carotid sheath, and posteriorly, and get a better idea that way. And so I would do that now, since you're in the operating room, and of course there's always the option if the patient's stable and you can control the bleeding with a Foley balloon at this stage. There's always the option to then proceed to CT angio or interventional radiology to get a better idea, and possibly stop the bleeding with stents if it's accessible. But it really, perhaps this is a salvageable case if the C-spine was struck low down, and he's a low cervical quadriplegic, then he's potentially salvageable. So I think you need to be aggressive at this point.
Thank you, Dr. Untract. Dr. Calais, Sao Paulo, your comments, please.
Yes. When I see this moment, I believe this patient will become someone who says stop. It's a vertebral artery injury. It's near the spine, near the transverse, the near the vessels, and it's very difficult to control hemorrhage in these situations because the vessels run through the tunnel of the bone, and then this tunnel is very difficult to control the hemorrhage. Sometimes you can dissect in this position the vertebral artery. You can try to tamponate, tie or maybe put a vessel loop on the surrounds of the vertebral artery, and then you can can tamponate with the hole near the spine and near the bones with Surgicel or other glues. If there is no possible to see it, you can tamponate and go to arteriography and try to see what's blending in these situations. But the great problem when it's near the spine is the vertebral artery. That's the way I go.
Thank you, Dr. Calais. Dr. Varon, are you prepared to comment at this time?
Well, now, you know, not being a surgeon, I think the management was okay, but can I share my screen for a second? If you stop sharing, let me share my screen for a second. Okay.
Good. Dr. Price.
Can I?
Yeah, stand by, please.
Okay.
Okay. Go ahead.
I just want to make a historical comment, which, you know, zone 1 injuries, as we know, have the highest mortality, but this is not a new concept. This is a sketch from Peter Paul Rubens showing Achilles kills Hector by stabbing him right there in zone 1. And that is why the Homer in the Iliad, chapter 22, said that zone 1 injuries is the shorter way to death. I just want to bring that up. So of interest. The point is that obviously these are deadly injuries. So it's great that you were able to get him all the way through. I agree with the approach, sticking your finger in there. If that works, that works. If not, a balloon tampon out. And median sternotomy probably is the fastest way so you can get proximal control. And then later on, once you solve that, then you can decide if the injury goes to the vertebrals, then probably angio will be the way to go. Well, that's my 2 cents.
Thank you for your 2 cents, Dr. Parrish. Very valuable. So while Dr. Price, okay, he's put that back up, let's just go real quick, see if Dr. Lieberman wants to weigh in before we return to Dr. Price.
Yeah, thanks for all the comments. I think they're definitely very helpful, and I like a lot of the insight you guys are providing. You know, I kind of had the easier part of the case because I just had my finger in the wound and I just didn't, you know, have to move or do anything. Whereas Dustin was the one struggling through the case. But as time passed and my finger was deep in that wound, I then kind of realized I was right up against the cervical vertebrae, and I could feel little kind of fragments of bone. And I realized I was compressing something right against the vertebral, the cervical vertebrae. And we kind of, you know, at that point, all of a sudden just realized that it had to be the vertebral artery. And there was a big chunk of it missing with bone fragments and just hematoma. And, you know, it's an artery that, you know, runs through the cervical vertebrae and is absolutely ridiculously almost impossible to get to. So I think the fact that we're at this point, the patient's still alive, I don't know if it's just skill or probably just a hell of a lot of luck.
Thank you, Dr. Lieberman. Let's continue, Dr. Price, if you would like.
Okay. Yeah, as Dr. Lieberman said, you know, you could really palpate the cervical spine, and we had a high suspicion for a right vertebral artery injury. I guess you could say, luckily, it was a destructive wound, so the hole within the neck was rather large. We were actually able to find the 2 ends of the right vertebral artery, which was, you know, easier said than done, but we were able to get control of the proximal end fairly easily and throw a silk ligature around it. The distal end was much more difficult to get control. We lost quite a bit of blood in the process, but were eventually able to suture ligate it and place several vascular clips around that vessel. And at this point, all the, at least surgical bleeding, seemed to be under control, but the patient was now becoming more coagulopathic. He started bleeding from the cut areas of muscle. We had to cut part of his SCM muscle, and that was bleeding. So at this point, this turned into more of a damage control situation. So we packed this bullet, the bullet tract with bone wax and quick clot. And that seemed to help quite a bit. And then we just placed a temporary vacuum assisted closure device on the right neck and the median sternotomy incision. Patient was then transferred to the trauma ICU for continued resuscitation. So in all, he lost about 5 liters of blood. He received 18 units of packed red blood cells, 14 units of FFP, 2 packs of platelets, and a unit of cryo. And everybody probably already saw this picture. This is we have a few intraoperative pictures. This is probably the one that came out the best to just at least demonstrate where the bullet tract was in relation to the great vessels, the subclavian and the common carotid. This was a CTA we obtained postoperatively. The red arrow is obviously pointing at the projectile within the spinal canal at C7 to T1. The arrow is also the trajectory of the bullet. So you can see it went just lateral to the common carotid. This is the CTA 3D reconstruction, which I found rather interesting. You can see the left vertebral artery coming off the aortic arch, and then the right vertebral artery stump where we had ligated. I would imagine it was just distal to where this cutoff is on the CTA. I would presume the remainder of the stump just didn't fill with contrast, because I don't think we were that low on the subclavian, but I do think this was the V1 segment of the vertebral artery. As far as his post-operative course, he did return to the operating room on post-trauma day 3. His right neck was hemostatic, so we were able to close him. We left a pericardial drain, mediastinal drain, and a right neck drain. At the index operation, we had placed chest tubes, initially one on the right side. He ended up getting one on the left side for difficulty with ventilation in the ICU, so he had bilateral chest tubes at this time. And then I can just briefly go over his very complicated hospital course, unless there's some discussion or if any comments on the management of that vertebral artery injury.
Dr. Untract.
Yes, I just had a question about, Dr. Lieberman said he was able to feel the transverse process of the C-spine, and, but what was your, how did you expose the vertebral artery to get control? What was your surgical approach? The
approach was directly through the bullet tract. There was myself, Dr. Lieberman, and Dr. Ferens, another fellow. So there's 3 of us in there. We had all basically just using handheld retractors were able to expose through the bullet tract and find the bleeding ends of the vertebral artery. Like I said, the proximal end was longer. It was easier to find. It was easier to ligate. The distal end was where it was more problematic. There's a lot of back bleeding coming from that end.
So it sounds like when you initially had control of the innominate artery, there was still a lot of bleeding. That was just the back bleeding from the distal end of the vertebral artery.
Right. I think, yeah, because theoretically with the clamp on the brachiocephalic, it should have controlled at least the proximal bleeding. But yeah, I think there was just a significant amount of back bleeding. And at that time, we hadn't ligated the internal jugular either. So I think it was bleeding from that at that time. So, in hindsight, it may have been better to leave the clamp on the brachiocephalic. But at that, when we had released it, we weren't sure this was going to be a vertebral artery injury. But.
And one last question, what came out of the 2 chest tubes?
Nothing. There was just air. Nothing. No hemothorax.
Dr. Calais, Sao Paulo, your comments, please.
Yes, I agree with the technical support of HTB. The great problem is the association with the spine injuries in this patient, and the great problem is the prognosis in this injury. But you have to do the best treatment for this injury. It's very important in the site of these injuries in this portion of the neck, the right on the left side. You can think sometimes the injuries of the vertebral artery, and you can go to try to stop in surgery like you do. Thank you for the presentation. It's a very nice case.
Thank you, Dr. Calais. Philadelphia, Dr. Alex, your comment, sir.
My question was if there was a CT of the head done at the same time with the CT angiogram of the neck, and then if there was any antiplatelet medication given after for, to prevent, a stroke from ligated vertebral. I see on the top line here that his neurologic outcome was did he have an anoxic brain injury, or was it a stroke from, you know, the vertebrae artery being ligated? So if you can comment on those two things. Thank you.
Sure. He did have a CTA of his head at the same time that we did the CTA of the neck, and it did show an intact circle Willis. No evidence of a intracranial ischemia. As far as antiplatelet, no, we did not treat him with any antiplatelet therapy postoperatively. He did have a component of an anoxic injury, but it wasn't his main issue. He does still have some residual brain damage from the anoxia, but he's also quadriplegic. He has minimal movement of his right upper extremity, and he is ventilator dependent, unfortunately.
Is that the extent of your question there, Dr. Alex?
Yes, thank you. Thank you.
Thank you. Dr. Kasim, Portland, your comments, please. Check your mic, sir.
Last year, Dr. Super showed us a case something like this, where he deployed the Fogarty catheter into the vertebral canal to stop the bleed. And he was successful in stopping the bleed and left the Fogarty catheter in for several days. I think he left it for 36 hours, something that I remember. But when you can see the two ends of the vertebral artery, then it becomes a duck soup. You can go ahead and ligate it with impunity. But of course, the problem is finding both ends. Sometimes it is not feasible to find the two ends when the artery is buried in the vertebral canal.
Yeah.
Well, you know, the team did a fabulous job, you know, very methodical and well thought out. And I appreciate the learning part of this case. Thank you so much.
Thank you, Dr. Kasim. Dr. Varon, your comment, sir?
Thank you.
Okay. Let's see, Dr. Lieberman.
Yeah, I just, you know, thank you everyone for all the input and the advice. And like I said, it's definitely helpful. Obviously, this is an exceptionally rare injury, and it's, I think, even more rare to survive it. If you want to call it surviving, I don't know if we did him any favors, being a quadriplegic, vent dependent, and stroked out. But honestly, I don't think the case would have been successful without my two fellows. They really were the ones that were able to keep this guy alive. And had the team been, you know, different, I don't think the outcome would have been the same. So excellent job to both of them. So thank you.
Thank you very much. Thank you for the presentation, Dr. Price. Do we have any other comments at all?
If I can just ask, so his level of consciousness now, is he sedated, or can you tell? Number one. And number two, you know, the ventilator dependence is probably because of the ventilator acquired pneumonia. And if he survives that, you know, it's possible that if his mental status recovers, he should not be chronically ventilator dependent because the phrenic nerve should be intact. It's a low cervical spinal injury. He's got some movement of the right arm. So, you know, and it's been several months, but it looks like he's potentially a young guy, salvageable as a quadriplegic. And, you know, and if he does survive, he might thank you for saving his life. I mean, if he gets, you know, lots of quadriplegics can go on to, you know, live satisfying lives afterwards. So, you know, I think you did the right thing, and I think, you know, it's important to be aggressive and at least give the family options, or the patient options, if he regains consciousness.
Thank you, Dr. Untract, for your comments. Other comments, please? Let's see, is Dr. Marttos still with us? Okay, no Dr. Marttos. Thank you, everyone. I'm sorry, go ahead, please.
Sorry, with regards to the timing of the tracheostomy, was When was the tracheostomy done? I thought I saw it was 33 days.
Yeah, it was about 30 days. He had a lot of issues with ventilator support that was presumed to be from massive transfusion, fluid overload. He was on very high PEEP and FiO2 settings. He developed ventilator and associated pneumonia. So I think a combination of things had prolonged his time to tracheostomy.
Thank you.
Thank you. Any other questions before we close? Comments? Thank you for the presentation, Dr. Price, and thanks for all the participants for joining us. Watch your email for information on the next session. And please, everyone, take good care of yourselves and be safe.
Thank you, Gary.
Thank you, everyone. Thanks for your comments.